This session includes 20 clinical questions, each with full rationales, so you're not just guessing. You're actually learning how to think like a nurse. And yes, we're covering all 6 NCLEX-RN formats: multiple choice, SATA, drag and drop, highlight the text, drop-down close, and those lovely matrix grids. Because NCLEX doesn't test you in one way, and let's be honest, they're really just checking if you panic under pressure. We won't. I'll walk you through clinical logic, common test traps, and those tricky answer choices that sound therapeutic but secretly delay care.
All right, question 1. Let's get right into it. A patient in the emergency department is experiencing a panic attack. Which nursing actions are appropriate in this situation? Sit with the patient and use short, clear phrases. Guide the patient in slow, deep breathing. Encourage the patient to discuss the origin of their anxiety. Move the patient to a low-stimulus environment. Offer caffeine-free cola to help them stay alert. Begin discharge teaching while calming them. Reassure the patient, "You are safe. I will stay with you." Take a second and think about which ones actually help this client feel safe and regulated, and which ones are sneaky distractors. Let's break this one down like a nurse would. Sit with the patient and use short, clear phrases. Yes, when someone's in full panic, don't overtalk. Keep it short, keep it steady. Guide them in slow, deep breathing. Absolutely. This is a foundational anxiety intervention. It interrupts hyperventilation and activates the parasympathetic response. Move them to a low-stimulus environment, 100%. Noise, lights, chaos, panic fuel. You want calm, quiet, and safe. Reassure the patient, "You are safe. I will stay with you." Yes, yes, yes. Don't underestimate the power of presence. This isn't just comfort, it's clinical grounding. Now, the common traps. Encourage them to discuss the origin of their anxiety. Sounds helpful, right? But not during a panic attack. That's for after they've de-escalated. Right now, cognitive processing is down. Offer caffeine-free cola. Not helpful. They don't need a beverage, they need to breathe. Begin discharge teaching. Classic NCLEX bait. Never educate a client during acute distress. Their brain can't retain it. Pro tip: when a client is panicking, think, be present, guide the breath, lower the stimulation, reassure with safety words. Everything else? Park it until later. All right, that's how we handle a panic attack like a test-smart nurse. Let's move to the next question.
All right, question 2. You're caring for a client with generalized anxiety disorder who started sertraline 5 days ago. She reports new onset insomnia, jitteriness, and a mild headache. Then she asks, "Is this medication making me worse?" Yes, the classic SSRI doubt spiral. Let's take a look at the answer choices. A, you should stop the medication and report this to your prescriber. B, these symptoms are common early in treatment and usually resolve. C, this is a sign of serotonin syndrome and you need urgent evaluation. D, it means the medication is working as intended. Go ahead and think through your answer. Got it? Let's break this down. The correct answer is B. These symptoms are common early in treatment and usually resolve. SSRIs like sertraline can cause temporary side effects. Things like jitteriness, sleep disruption, or a dull headache. These aren't signs of danger. They're signs the body is adjusting to the medication. Now let's look at the tempting traps. A, stop the medication? Not a good move. Stopping abruptly can actually make symptoms worse and increase withdrawal risk. C, serotonin syndrome? It may look similar on the surface, but we're missing the big red flags: fever, muscle rigidity, hyperreflexia, or altered mental status. Mild jitters alone don't qualify. D, it means it's working? That's a stretch. These are side effects, not therapeutic effects. They're tolerable, not desirable. Here's the NCLEX tip. Always know what's expected early on, what's dangerous, and what just needs a little education and reassurance. SSRIs have a slow start and some early side effects. Teach your patient to hang in there and don't jump ship on day 5. Let's keep going.
Let's walk through a drop-down question focused on safe medication teaching.
A client is prescribed alprazolam PRN for acute anxiety. The nurse provides discharge instructions. You'll complete the statement using clinical judgment. Select the most important teaching point from each drop-down. This medication is drop-down 1, slow-acting or fast-acting or non-addictive, and should be drop-down 2, taken daily or used only as needed, or used with alcohol to enhance effect. Avoid drop-down 3, driving or sleeping or dairy products until you know how it affects you. Correct answer is, this medication is fast-acting. It should be used only as needed. And you should avoid driving until you know how it affects you. Let's break it down. Alprazolam is a fast-acting benzodiazepine. It's commonly prescribed for panic episodes or severe acute anxiety, but it comes with significant risks, including sedation, dependency, and CNS depression. It should only be taken as needed and only as prescribed. Daily or unsupervised use can lead to tolerance, withdrawal, or worse. And driving? Not safe until the client understands how the drug affects alertness and coordination. Benzodiazepines slow reaction time, and NCLEX always flags that as a safety hazard. Here's what this question teaches. Not all medications are PRN friendly. Some, like buspirone, require scheduled use, but benzodiazepines demand caution, supervision, and very clear patient education. Let's keep going.
Talk medication teaching, the kind NCLEX loves to test. You're discharging a client who just started sertraline for generalized anxiety disorder. You review the plan, and then the client says something that raises a flag. Here's the question. Which of these statements by the client indicates a need for further education? A. It might take a few weeks before I feel less anxious. B. This medication will help stabilize my mood over time. C. If I feel anxious in the moment, I can take an extra dose. D. I'll let my provider know if I start having thoughts of harming myself. Think it through. Which one shows a misunderstanding about how this medication works? The correct answer is C. If I feel anxious in the moment, I can take an extra dose. That's not how SSRIs work. Sertraline, like all SSRIs, builds slowly. It typically takes 2 to 4 weeks to start making a noticeable difference. It does not provide quick relief. Taking an extra dose when you feel anxious isn't effective, and it could cause side effects. SSRIs are designed for long-term regulation, not acute symptom relief. That's why benzodiazepines exist, and even those must be used carefully. Now let's check the other responses. A. That's accurate. SSRIs do take time to work. B. Correct. Stabilizing mood over time is exactly the goal. D. That's not just right, it's a vital safety cue. Clients should always report suicidal thoughts immediately. Here's your NCLEX takeaway. When teaching about SSRIs, always emphasize 3 things. They don't work immediately, they must be taken daily, and they're never used like painkillers, no extra pills on a rough day. That's a safety concern, not a solution. Nice work. Medication education is one of the most NCLEX rewarded skills, and now you've got it down. Let's move on. All right, a safety-focused question NCLEX loves to sneak in. A client just received lorazepam IV for acute panic. Now you're monitoring them closely. Which of the following findings requires immediate action? A. Slurred speech. B. Drowsiness. C. Shallow breathing. D. Low normal blood pressure. Think about the route, think about the drug. Which one of these jumps out as not okay? The correct answer is C. Shallow breathing.
Benzodiazepines, especially when given intravenously, can suppress the respiratory system. That's your biggest risk. Drowsiness and slurred speech? Expected, maybe annoying, but not dangerous. Low normal blood pressure? Also expected. You're not chasing perfect vitals here, just making sure they don't crash. But shallow breathing? That's the red flag. That's your cue to act fast. Why? Because respiratory suppression isn't just a side effect, it's a potential sign of overdose. And with IV meds, absorption is instant. There's no room for delay. Here's your NCLEX tip. When a question involves IV benzodiazepines, your internal alarm should go off. Watch for respiratory depression, oxygen saturation, level of consciousness. Those are your safety triggers. This is classic NCLEX. You're not guessing, you're separating what's expected from what needs to be escalated. Let's keep building that judgment. Next question.
All right, this one's about therapeutic communication and safety. A client with major depression says to the nurse, "I think my family would be better off without me." Okay, what's your next move? Let's look at the options. A. Have you discussed that with your family? B. Are you thinking about hurting yourself? C. Everyone feels that way sometimes. D. Try to focus on the positives in your life. Which of these is safe? Which of them actually opens the door to what this client needs? The correct answer is B. Are you thinking about hurting yourself? Firm and clear. This is not just okay, it's exactly what NCLEX wants. Direct, therapeutic, and safe. You do not increase risk by asking directly. In fact, it shows you're clinically aware and emotionally available. Now let's look at the others. A. Have you discussed it with your family? Way too early. That redirects away from the real issue. C. Everyone feels that way sometimes. That's minimizing. It dismisses serious pain. Try to focus on the positives? Sounds nice, but it shuts down the conversation. And in this moment, you need to open it. When you see signs of suicidal ideation on NCLEX, don't sugarcoat. Go direct. Ask clearly. Show clinical concern. Phrases like, "Are you thinking of hurting yourself?" or "Do you have a plan?" are therapeutic gold. That's what patient-centered nurse-smart care sounds like. All right, therapeutic communication is one of your biggest scoring areas on NCLEX. You nailed this one. Let's move on.
Time for a pharmacology safety check. You're caring for a client who's receiving haloperidol. They report a stiff neck, difficulty swallowing, and facial spasms. Now ask yourself, what's your first move? Let's look at the options. A. Reassure the client that this is a normal side effect. B. Administer benztropine as prescribed. C. Hold the next dose and notify the provider tomorrow. D. Apply warm compresses to relieve the muscle stiffness. Think carefully. Don't just choose what sounds nice. Choose what protects the airway. The correct answer is B. Administer benztropine as prescribed. These symptoms are red flags for acute dystonia, a type of extrapyramidal side effect. It can progress quickly, even to laryngeal spasms that block the airway. Benztropine or diphenhydramine should be given immediately, IM or IV. This is not a wait-and-see moment. Let's go through the wrong answers. A. Reassure the client? No. That delays urgent treatment. This isn't normal. D. Warm compresses? Not enough. That's comfort care, not emergency care. C. Notify the provider tomorrow? Absolutely not. This needs to be addressed now, not later. Here's your NCLEX tip. When you see signs of EPS, especially muscle stiffness, facial tension, or difficulty swallowing, ask yourself, could this be dystonia? Could it affect the airway? If the answer is yes, treat it now. Document later. This is how NCLEX checks whether you'll act quickly when safety is on the line, and in this case, you did.
Now, let's talk about a medication that shows up often on NCLEX, but doesn't get enough attention in school. Buspirone. It's prescribed for generalized anxiety disorder, and this one's all about client teaching. Here's the question. Which statement by the client reflects correct understanding? A. I can take this every few hours if I feel anxious. B. This medication may make me sleepy right away. C.
I need to avoid grapefruit juice while taking this. D. This medication works better if I use it with a benzodiazepine. Now ask yourself, which one shows the client really understands how this drug works? And which one make your nurse radar go off? The correct answer is C. I need to avoid grapefruit juice while taking this. Grapefruit inhibits the CYP450 system, slowing metabolism of buspirone and increasing the risk of toxicity. It's a high-yield interaction that NCLEX loves to test. Now let's break down the distractors. A. Taking it every few hours? That's incorrect. Buspirone is not a PRN med. It needs to be taken on a schedule consistently to be effective. B. Sleepy right away? Not likely. Buspirone is non-sedating, which is part of what makes it safer, but also slower. D. Works better with a benzodiazepine? That's not just wrong, it's dangerous. We don't layer CNS depressants unless there's a very specific reason, and NCLEX isn't giving you one here. Here's your NCLEX tip. When it comes to buspirone, remember 4 key things. It's slow-acting, it's non-addictive, it's non-sedating, and it's grapefruit sensitive. It's a great long-term choice for generalized anxiety disorder, but not something you'd reach for during a panic attack.
Let's walk through a question that's all about recognizing the right anxiety disorder. And yes, NCLEX loves to blur the lines on this. You're assessing a client with a history of public embarrassment. Now they avoid all social gatherings and express a strong fear of being judged or humiliated. What diagnosis should the nurse suspect? A. Generalized anxiety disorder. B. Panic disorder. C. Social anxiety disorder. D. Agoraphobia. Think about it. What's the actual trigger here? Is it fear of crowds, fear of judgment, random panic episodes, or generalized worry? The correct answer is C. Social anxiety disorder. This client has a clear, consistent fear of being judged in social settings. That's the hallmark of social phobia, now called social anxiety disorder on the NCLEX. Let's take a closer look at the other choices. A. Generalized anxiety disorder. That's persistent worry about many areas of life, not just social situations. B. Panic disorder. That involves sudden panic attacks that feel random or unpredictable, not fear tied to one setting. D. Agoraphobia. Close, but not quite. Agoraphobia is the fear of being trapped or unable to escape, like in crowds, public transit, or unfamiliar places. This client isn't afraid of the environment, they're afraid of being judged. Here's your NCLEX tip. When it comes to anxiety disorders, match the pattern of fear to the correct label. Fear of judgment, that's social anxiety. Fear of losing control in public, agoraphobia. Fear of everything all the time, GAD. Fear that hits out of nowhere, that's panic disorder. Think in categories, not just keywords. Nice work. Let's keep building those diagnostic instincts. Next question coming up.
Time for select all that apply questions, and you already know what I'm going to say. Take a breath, you're stronger than the SATA. Here's the scenario. A client is being evaluated for generalized anxiety disorder. Which findings should the nurse expect? Restlessness or feeling on edge? Muscle tension? Difficulty concentrating? Sleep disturbances? Hallucinations? Euphoria? Fatigue? Look for the pattern, not just one symptom. GAD is like the background noise of anxiety, always there, always exhausting. Let's go through the correct answers. Restlessness? Absolutely. It's one of the most common signs. Muscle tension? Yes. GAD often shows up in the body just as much as in the mind. Difficulty concentrating? Correct. Racing thoughts make it hard to focus. Sleep disturbances? Very common. Clients may have trouble falling asleep or wake up anxious. Fatigue? Of course. Chronic anxiety wears the body and mind down. Now let's talk about the outliers. Hallucinations? Not part of GAD. That's a psychotic feature and a red flag for a different diagnosis. Euphoria? That's more consistent with mania.
If the client is unusually cheerful and energetic, it's not anxiety. Here's your NCLEX tip. GAD is persistent tension, physically, mentally, emotionally. Look for restlessness, tight muscles, foggy thinking, poor sleep, and fatigue. Eliminate anything that sounds too extreme, like hallucinations, or too cheerful, like euphoria. Think tension, tiredness, and too much thinking.
Here's another select all that apply. This one is all about safety with alprazolam, one of NCLEX's favorite benzodiazepines. The nurse is teaching a client who was just prescribed alprazolam for acute anxiety. Which safety instructions should be included? Avoid alcohol during therapy. Report signs of confusion or memory issues. Do not abruptly stop taking the medication. Avoid operating heavy machinery. And you may take an extra dose during a panic attack. Take on an empty stomach for best absorption. Okay, time to pick the ones that keep your patient safe and out of trouble. Let's start with the correct answers. Avoid alcohol, always. Alcohol plus benzodiazepines leads to sedation overload, respiratory depression, and impaired judgment. Report confusion or memory issues. Yes. These may indicate early toxicity or developing dependence. Do not abruptly stop taking the medication. Absolutely. Sudden withdrawal from benzos can lead to seizures. Tapering is essential. Avoid operating heavy machinery. Yes, these medications slow reaction time. Driving or using equipment while on benzos is unsafe. Now let's clear out the incorrect options. You may take an extra dose during a panic attack. No, that's self-medicating. Dosing decisions must come from the prescriber, not the client. Take on an empty stomach for best absorption? Not relevant. This isn't a medication like iron or levothyroxine. Alprazolam can be taken with or without food. Here's your NCLEX tip. When you see benzodiazepine safety questions, look for the do nots. Don't drive, don't drink, don't stop suddenly, don't ignore cognitive changes, and don't self-adjust doses. The prescriber sets the plan, not the patient. That's how you protect your client and earn points with NCLEX at the same time. This next one matters, not just for the test, but for real-world nursing. A client recently experienced a traumatic home invasion, and you're assessing for post-traumatic stress disorder, PTSD. Let's review what the client says and what those statements really mean. I keep reliving the attack when I close my eyes. I feel numb and avoid things that remind me of it. Sometimes I think it was just a dream. Loud noises make me jump and panic. I can't sleep and I feel on edge all the time. I've started binge eating when I feel upset. Which of these line up with PTSD, and which ones point somewhere else? Let's start with the classic PTSD cluster. I keep reliving the attack. That's intrusion, a core symptom. Flashbacks, nightmares, mental replays. It's one of the strongest indicators of PTSD. I feel numb and avoid things that remind me of it. That's avoidance and emotional numbing. Clients may steer clear of conversations, places, or anything associated with the trauma. Loud noises make me jump and panic. That's hyperarousal, the exaggerated startle response and hypervigilance that often follow trauma. I can't sleep and I feel on edge all the time. Also part of arousal. Sleep disturbance is one of the most common features of PTSD. Now let's look at the statements that don't support the diagnosis. Sometimes I think it was just a dream. This could reflect confusion or emotional detachment, but it's not a diagnostic symptom on its own. I've started binge eating when I feel upset. That's a coping mechanism, not a PTSD marker. It might suggest an eating disorder or mood-related issue, but not enough here to diagnose PTSD. Here's your NCLEX tip. PTSD is defined by the IAA triad: intrusion, avoidance, arousal. Stick to those themes and you'll filter out the distractors. Anything that sounds like an eating disorder, mild sadness, or general stress, probably not PTSD. You're not just identifying symptoms, you're connecting patterns to diagnoses. That's clinical judgment in action. Let's move on to the next one.
Here comes a high-stakes scenario.
A client receiving haloperidol suddenly develops severe neck spasms, eyes rolling upward, and an inability to swallow. The nurse suspects extrapyramidal symptoms, specifically an acute dystonic reaction. So, what should you do? Let's walk through your options. Administer prescribed benztropine IM. Notify the healthcare provider. Reassure the client these effects will pass on their own. Monitor airway and breathing closely. Document the incident thoroughly. Place the client in restraints to prevent movement. This isn't just about comfort. This could be about airway, so prioritize accordingly. Let's go through the correct responses. Administer benztropine IM. Yes, this is the go-to treatment for acute dystonia. Fast, effective, and potentially life-saving. Give it IM or IV, but don't wait. Notify the provider. Definitely, but only after you intervene. NCLEX expects you to act first, report second. Monitor airway and breathing. Yes, these spasms aren't just uncomfortable. They can involve the larynx, and if the airway closes, you've got a bigger emergency. Document the incident thoroughly, always. Once the client is stable, chart everything. EPS events are serious and require follow-up. Now for the unsafe choices. Reassure the client it'll pass on its own. No, that's not just false reassurance. It delays critical treatment. Restraints never. These spasms aren't behavioral. This is a medical emergency, not aggression. Here's your NCLEX tip. If you see eye-rolling, neck spasms, or difficulty swallowing, recognize it for what it is, acute dystonia. And if there's a risk to the airway, remember your top 3. Treat, protect the airway, call the provider.
Here's an ordered response that tests your ability to prioritize in real time. A client is experiencing a sudden panic attack in the emergency department. What should the nurse do, and in what order? Guide the client to take slow, deep breaths. Stay with the client and offer calm reassurance. Move the client to a quiet environment. Use grounding techniques like name 3 things you see. Once calm, explore possible triggers or recent stressors. Which of these comes first when someone is spiraling into panic? Here's the correct order: 2, 1, 3, 4, 5. Let's walk through it. Step 1. Stay with the client and offer calm reassurance. This is always the first priority. Don't leave a client alone during a panic episode. Your presence sends a clear message: they are safe. Step 2. Guide the client to take slow, deep breaths. Once you've established presence and safety, help the client regulate their physiology. Breathing calms the nervous system and breaks the panic loop. Step 3. Move the client to a quiet environment. Now that the client is starting to breathe, reduce external stimulation. Lights, noise, people. Give them space to reset. Step 4. Use grounding techniques. Once their body is calm, help focus the mind. Simple tools like name 3 things you can see or 2 things you can touch promote control and orientation. Step 5. Explore possible triggers or stressors. Only after the client is calm and regulated. Never attempt to analyze the panic mid-crisis. That's a common NCLEX trap. Here's your NCLEX tip. Panic attack management follows 3 key phases: presence, physiology, processing. If you try to process too soon, you risk overwhelming the client or missing the moment to de-escalate. Great work. Prioritization isn't about guessing. It's about knowing what the client needs first. Let's go deeper. Next question coming up.
All right, this one is high stakes and high yield. A client on fluoxetine arrives at triage with confusion, agitation, fever, tremors, and diaphoresis. You suspect serotonin syndrome. What's your nursing response and in what order? Here are your actions. Stop the serotonergic agent immediately. Notify the healthcare provider urgently. Apply cool blankets and monitor temperature. Administer prescribed benzodiazepines for agitation. Prepare for IV fluids and cardiac monitoring. Let's line this up like a nurse in crisis mode. The correct order is 1, 2, 3, 3, 5. Step 1. Stop the serotonergic agent. This is the golden rule. When serotonin syndrome is suspected, the first move is to discontinue the medication immediately. That's your fastest way to stop the condition from progressing. Step 2. Notify the provider. Once you've taken action, escalate the situation. This is a life-threatening reaction. The provider needs to be informed now, not in 30 minutes. Step 3. Apply cool blankets and monitor temperature. Fever and autonomic instability are hallmark features. Cooling interventions are essential for symptom control. Step 4. Administer prescribed benzodiazepines. This helps manage neuromuscular overactivity, including tremors, agitation, and even seizure risk. Step 5. Prepare for IV fluids and cardiac monitoring. This supports perfusion and helps track potential arrhythmias if vital signs start to shift. Here's your NCLEX tip. When it comes to serotonin syndrome, your job is to do two things and do them fast. Stop the trigger, treat the symptoms, in that order. Prioritization questions like this aren't just about memory. They're about thinking clearly under pressure, and you did that here. Let's switch gears and head into some Next Gen Style highlight the text questions.
This one is subtle, but critical. You're reading a statement from a client who's depressed, withdrawn, and starting to say things that hint at giving up. Your job is simple. Spot the red flag. Here's what the client says. I just don't see the point anymore. My kids are grown and I've already done what I needed to do in life. They'll be better off once I'm gone. I've been giving away my books and some of my jewelry, just clearing things out. I finally feel at peace and I know what I need to do. Now think carefully. Which line signals immediate suicide risk? The correct highlight is, they'll be better off once I'm gone. Also acceptable? I finally feel at peace and I know what I need to do. This is one of the most important red flags on the NCLEX. A client expressing a sense of burden, finality, and sudden emotional peace after a period of distress, that's not just sadness, that's suicidal thinking. They'll be better off without me. This shows the belief that their death will improve others' lives, a critical mindset to catch. I finally feel at peace and I know what I need to do. That often means the client has made a plan and reached a dangerous point of resolve. Even the act of giving away possessions like books and jewelry is a behavioral cue, and NCLEX expects you to recognize it. Here's your tip. Suicide risk isn't always loud. Sometimes it's quiet, calm, and resolved because the decision has already been made. That's when you act, not later. You don't need a diagnosis to intervene. You need clinical judgment and the willingness to ask the right questions. Let's keep sharpening that skill. Next,
Now let's practice spotting the pattern in a medical emergency. A client on fluoxetine, that's an SSRI, shows up at the ED. Here's the triage note. Listen carefully and get ready to highlight the signs that scream serotonin syndrome. Client is a 24-year-old female on fluoxetine, reports feeling shaky and restless, has tremors in both hands, elevated temperature of 39.2 degrees centigrade, and a heart rate of 128 BTM. Pupils are dilated. Also notes muscle rigidity and says she feels confused. What would you highlight? What tells you this is serotonin syndrome, not just anxiety, heat, or stress? Correct highlights: tremors in both hands, elevated temperature, heart rate of 128 BTM, muscle rigidity, confusion. These findings fit the classic triad of serotonin syndrome. Autonomic instability, that's your fever and tachycardia. Neuromuscular excitation, think tremors and rigidity. Altered mental status, like confusion or agitation.
And if you caught all of those, gold star. The pupil dilation and feeling shaky could be anxiety, not specific enough. But that cluster, tremors, fever, high HR, confusion, rigidity, that's your emergency pattern. NCLEX expects you to see it. Teacher tip: when NCLEX gives you clusters of symptoms, don't isolate, connect. Serotonin syndrome isn't one red flag, it's a combo attack. You're learning to think like a nurse, not just spot symptoms, but link them together. Let's move on to the next scenario. All right, time to attend drop-down cloze question, one of NCLEX's favorite new formats. These force learners to choose the best phrase or concept from drop-downs embedded in this scenario. Based on your psychopharmacology and anxiety content, these target decision-making, safety, and drug mechanism knowledge. You're teaching a client who's just been prescribed buspirone for generalized anxiety disorder. Let's fill in the blanks like a nurse who knows their pharmacology. Buspirone is used for drop-down 1, acute or long-term or crisis management of anxiety. It typically, drop-down 2, starts working immediately / takes 2 to 4 weeks to be effective / causes sedation within an hour. It is important that you take it, drop-down 3, on a PRN basis or at scheduled times or only when you feel symptoms. Let's break it down. Drop-down 1, long-term. Buspirone is a great option for chronic anxiety, not acute panic. It's non-addictive, non-sedating, and designed for long-term use. Drop-down 2. Takes 2 to 4 weeks to be effective. That's key. Clients need to understand they won't feel immediate relief. Buspirone is a slow builder, not a quick fix. Drop-down 3. At scheduled times. This is critical. Buspirone must be taken consistently to be effective. It does not work if taken only when symptoms arise. So if your client says, "I'll just take it when I feel anxious," that's a red flag. That means they need more teaching. Here's your NCLEX tip. Buspirone and benzodiazepines are opposites in many ways. Benzodiazepines equals fast, PRN, addictive, sedating. Buspirone equals slow, scheduled, non-addictive, non-sedating. That contrast shows up often on NCLEX. Know it cold. Great work. You're not just filling in blanks, you're reinforcing real clinical education. Let's keep the momentum going with the next drop-down.
This one's about antipsychotic safety. A client on risperidone shows up with new symptoms. Question: a client on risperidone reports new symptoms during a clinic visit. Choose the best interpretation for the nurse's documentation. Client reports, drop-down 1, blurred vision, facial twitching, dry mouth, and drop-down 2, fever, insomnia, increased salivation. Nurse notes muscle stiffness and a resting tremor. Findings suggest possible, drop-down 3, EPS or NMS or withdrawal. Correct answers: facial twitching, fever, NMS, neuroleptic malignant syndrome. Facial twitching. That's not dry mouth or visual blur. This is neuromuscular activation and a red flag for movement disorder onset. Fever. This changes everything. Fever paired with rigidity? Think NMS first, always. NMS. Neuroleptic malignant syndrome is a life-threatening reaction to antipsychotics. The giveaway? The combo of fever, rigidity, and mental status changes or tremors. EPS might look similar, but EPS doesn't usually come with fever. Withdrawal is a distractor. Nothing here fits that profile. Teacher's tip: when a client on an antipsychotic develops fever plus stiffness, assume NMS until proven otherwise. Here's the triad to remember: fever, rigidity, autonomic instability or mental status change. Immediate action is required. This is not watch and wait territory. Nice work. These drop-downs build your pattern recognition and safety instinct, one phrase at a time. Let's close this set strong with your final 2 matrix grid case questions. All right, time to level up your clinical judgment with a matrix web item. You're following up with a client who started sertraline, an SSRI, 10 days ago for generalized anxiety disorder. You'll hear 5 client statements. For each one, decide if it's expected, needs follow-up, or RUEN, requires immediate action. Let's go one by one. Statement 1. I feel more nervous than usual and I'm not sleeping well. Expected. SSRIs often cause increased anxiety, jitteriness, or insomnia during the first 1 to 2 weeks. No need to panic here, just reinforce that this typically improves with time. This is a normal adjustment, not medication failure. Statement 2. I've been having thoughts about harming myself, but I haven't done anything. Requires immediate action. Any mention of suicidal ideation, even without a plan, is a safety crisis. NCLEX doesn't want you to wait or talk around it. This demands direct follow-up and escalation. Statement 3. I know the medication takes a while, so I'm trying to be patient. Expected. That's actually a great response. Shows insight, adherence, and realistic expectations. No red flags here. This client gets it. Statement 4. I stopped taking the medication yesterday because it was making me nauseous. Needs follow-up. Stopping SSRIs abruptly can cause discontinuation syndrome, and it also means the client is unprotected. This needs education, reinitiation guidance, and maybe side effect support, but it's not emergent. Statement 5. I've been drinking more wine than usual to calm down. Needs follow-up. Mixing SSRIs with alcohol can lead to increased sedation, poor coping, and med interactions. It's not a 911, but it's definitely worth addressing before it becomes one. Teacher tip. Matrix questions aren't about knowing what's wrong. They're about knowing what's okay for now, what needs a nurse check-in, and what sends you straight to crisis protocol. Always put suicidal ideation, airway, and cardiac risk in the immediate action box. Great judgment call. Let's move to your next case scenario and keep testing your triage instincts.
All right, your client is taking haloperidol, and now they're showing you symptoms. NCLEX wants to know which ones are signs of EPS, which point to NMS, and which are just unrelated. Let's break them down one by one. Tremors and a shuffling gait. Associated with EPS, this is classic Parkinsonism, an extrapyramidal symptom. Think tremor, slow movement, and that hunched, shuffling walk. You'll often see this after prolonged use of first-gen antipsychotics. High fever and altered mental status. Associated with NMS, this is your red flag combo. Fever, confusion, neurosymptoms. That's neuroleptic malignant syndrome until proven otherwise. Treat it like an emergency. Mild headache and dizziness on standing, unrelated to EPS or NMS. This sounds like orthostatic hypotension. Not uncommon, but not dangerous. No tremors, no fever, no rigidity, just low blood pressure doing its thing. Oculogyrate crisis and facial muscle spasm, associated with EPS. These are signs of acute dystonia, a fast onset EPS reaction. The eye rolls up, the face locks, and it can look dramatic. Treat it with benztropine or diphenhydramine IM or IV. Fast. Diaphoresis and muscle rigidity, associated with NMS. Again, this is autonomic instability plus neuromuscular symptoms. Add fever or confusion to this, and you've got full-blown NMS. Don't delay. Stop the med, call the provider, cool them down, and support their vitals. Teacher tip: EPS equals movement problems. NMS equals movement plus fever plus mental status changes. When in doubt, if the temperature is high, assume NMS. If they're just stiff and twitchy, likely EPS. That wraps your matrix practice. And now you've got a sharper eye for medication reactions that matter. Let's bring it home. You just worked through 20 high-yield NCLEX-RN questions across every format, from SATA and multiple choice to drag and drop and highlight the text. That's not easy, but guess what? Neither is nursing, and you're clearly building the mindset to handle both. When you have a lot the school stas and machining and the pest works, include them. If you learned something today, or caught yourself saying, "Oh, that's what NCLEX wants," then you're right where you need to be. Comment which topic Q&A you want next. You see that accent's the best in the 2009, but I'm in wanting the centame waitfully the school's at. We're long in bowling to me, we're again within the thank you.